This is a case describing the basic concepts of endoscopic drainage of a mediastinal abscess. A 49-year-old gentleman with past medical history of recurrent pancreatitis secondary to alcohol use was admitted with fever, dry cough, and shortness of breath. CT chest revealed left pleural effusion, mediastinal abscess, and recurrent pancreatitis. A PD stent was placed, given the concern for pancreaticopleural fistula, which led to the resolution of the pleural effusion. On the CT chest, here you can see the mediastinal abscess. You can see that the abscess is close to the distal esophagus and cardia, and therefore appropriate for endoscopic drainage. You can see the extensive compression in the distal esophagus extending 2 to 3 centimeters into the cardia. In the retroflex view of the cardia, you can see the extensive compression better, along with overlying ulcerated area in the mucosa. There is also a whitish raised area with slow active discharge of purulent fluid consistent with the underlying abscess. In order to further investigate the abscess, we proceeded with the radial EUS examination. You can see that there is a multiloculated hypoechoic heterogeneous fluid collection at the GE Junction which extends into the cardia. The abscess ranges in size from 2 to 4 centimeters. Next, we proceeded with a linear endoscopic ultrasound to evaluate the abscess for possible drainage. You can see that the abscess is not walled off and the wall is not mature. Otherwise, we would have placed an axios stent here. In order to facilitate continued drainage of the abscess, we elected to place a plastic stent. We are now introducing a 19 gauge needle for fine needle aspiration. We aspirated the fluid, which was turbid in consistency and consistent with abscess. Next, we have removed the attached suction syringe while maintaining the needle in place in the abscess cavity, and we are now loading the 19 gauge needle with a 0.235 inch stiff jag guide wire. Remember, if you're using a 22 gauge needle for drainage, then you won't be able to use the stiff jagwire and you will have to use some thinner guide wire. In this case, you can use any wire as long as the wire is stiff, because that will help to keep the wire in place while you're exchanging the wire. Next, we are dilating the tract with a tandem catheter. The distal tip of the tandem catheter is 5.5 French, whereas the main body is 7 French. So theoretically, you can place a 7 French stent after you have dilated the tract with the tandem catheter. Keeping the wire in the abscess cavity, we are now placing a 7 French 4 cm double pigtail plastic stent by advancing it over the wire under EUS guidance. The 7 French 4 cm stent was successfully deployed and positioning was confirmed on both EUS imaging and endoscopic view. A double pigtail stent was placed to decrease the chances of migration of the stent both into the abscess cavity and also into the esophageal lumen. Purulent fluid was seen extruding from the stent at the end of the procedure. And you can see here that we are confirming that the stent is in the abscess cavity under the endoscopic, under the ultrasound view. Once we have confirmed that the stent is in place, we are now confirming that the stent is in place and with the endoscopic view. You can see the post-procedure CT scan, which shows that the stent is in place with resolution of the abscess. Patient did very well and was discharged home. Thank you for watching.